today we're going to be talking about Cushing's disease. And if I'm talking too fast, raise your hand, okay? Doctor, anybody, okay? I'm going to try to put marbles in my mouth so it slows me down a little. So right now, I'm going to really focus more on treatment and the testing, you know. And please feel free to ask questions at any time throughout this presentation. So I think that most of the time with Cushing's, we're all pretty familiar with the signalment and clinical symptoms. So I'm not really going to go into too much detail, but of course it's middle age to older dogs. It's really slowly progressive. And the biggest complaint that people would see with their pet is PUPD and polyphagia, and sometimes lethargy, but a lot of times really the top two is really the PUPD and polyphagia. But you'll see a little bit excessive panting and some coat changes. It doesn't have to have all the clinical symptoms, but really any one of those. I really want to emphasize that the animal should not be vomiting or having diarrhea or anorexia. I notice that sometimes there's a lot of sick animals that ultimately are worked up, and they'll do a Cushing's test. You know, and for animals not feeling well, but you see the liver enzymes really high, the cholesterol is really high, that's really not going to be the cause of the anorexia or depression. So I really recommend not doing an ACTH stimulation or low-dose DEX, or really just testing for Cushing's at that time, because you will get false positives, because it's under stressful conditions that the animal can have a false positive. And sometimes you'll get in this predicament where we'll see that they're trying to test for Addison's and Cushing's at the same time when you have these weird, bizarre situations. And again, when you have those two on your differential, probably something else is wrong. I think probably the biggest cause for the really high ALK phos and high cholesterol is probably, pancreatitis is probably the most common. And usually they're vomiting or not feeling well. So again, Cushing's should be lower on your list. You have concurrent disease where a lot of Cushingoid dogs do get pancreatitis. So of course they can have high ALK phos and cholesterol, but it really shoots up high because there's some congestion of bile or so. So I do think that a lot of Cushingoid animals can truly become ill because they are often older animals anyways. But just make sure you try to separate out the two. And a lot of times Cushing's is not an emergency disease, so you should be really focusing on why the animal is sick, not eating, versus trying to work down the Cushing's road, which it may still need to be done in the future, but often is not the primary cause. So the main types of hyperadrenal corticism would be pituitary-dependent and adrenal tumors. Majority are pituitary dependent, 80 to 85%, and adrenal tumors around 15%. And in rare cases, there are cases where both diseases are present. And so you'll have this kind of frustrating case where you'll actually find on an abdominal ultrasound both adrenal glands are very large, but one is more mass-like, but the other side is actually not atrophied and it's still large. And I want to stress that you really shouldn't confuse hyperadrenal corticism with pseudo-Cushing's, like the alopecia X that you guys probably have seen, like a Pomeranian or a Malamute or some kind of dog that's like totally bald, but there's really no PUPD, there's no other clinical symptoms except for the dermatological changes, because it's really not a high cortisol issue. And then there's atypical Cushing's, which you guys may be kind of hearing this terminology thrown around, where you're testing for Cushing's, but everything's negative, but you're still very suspicious. Clinical symptoms are still there. Blood work is still also consistent with Cushing's, like high ALK phos, high cholesterol. And we'll kind of go a little bit over that too. So which test should you use? So probably the cheapest test you can try to do is have the meat there and it's animal sitting there, doesn't touch it, it's probably not going to be Cushing's. But I have to say this is a very poor sensitivity, specificity, but very sensitive. And you really should be familiar with these tests that will be coming up regarding Cushing's, because sometimes you really want to select a very sensitive test, but there are other times you really want a specific test. Unfortunately, we don't have one single test that will have high both sensitivity and specificity. So I'm going to go down for the most sensitive test. The most sensitive test is the urine cortisol creatinine ratio. It's about 75 to even 100%, and it's probably more like the 90s to 100%. but it's horrible in specificity. So it's a really great test if you feel that Cushing is on your differential list, but it's really not the highest one, okay? But yet you feel like you have to still go through the motions of making sure that's not what's going on. So if I'm trying to rule out Cushing's, and it's not really high on my list, but unfortunately it still is a differential, you should have the owner catch a urine and then do a urine cortisol creatinine ratio. The downside is that if you get a positive, you have to keep going on with the other Cushing's tests. But it is pretty easy to get, and really it's just really important to remember that if you have any other concurrent illness, like a diabetic animal, you're trying to find out their Cushing's or not, it's just not a very good test, because any illness will have high stress levels that will give a false positive on the urine cortisol creatinine ratio. So the next test that is actually the most sensitive, which is not bad, 90-95%, is a low dose dex suppression test. It's the 0.01 mg per kg IV, and you really want to diagnose Cushing's based on the 8-hour post. I know a lot of people like try to get you to look at the 4-hour, which is still not a bad idea, but it's not perfect. So the specificity on this disease is really 44 to 73%, so definitely not a great test if you have other non-adrenal illnesses going on. Okay, you'll get a lot more false positives. So you can sometimes give you some clue about adrenal tumor versus pituitary dependent, but really about 65% of pituitary dependent will have all three issues, which is 8-hour post-cortisol is greater than 1.4, but less than 50% of the basal value, and then in 4 hours it'll be less than 1, and then eventually, so it suppresses a little bit, and then ultimately it still goes up after 8 hours. Okay, but you have to realize it's only 65%, so it's almost 50-50. You still, a lot of people kind of look at that 4-hour, but really you still have a almost 50% chance of either one. So to me, I don't really look at the 4-hour as much, but you should still do it because it's part of the whole test. I like this test because of the sensitivity. It is very high. Then you have the high dose dex suppression test. I'm going to be honest, this is kind of going out of fad for a lot of internists because again, there's just too much overlap. And I think because we have better testing capabilities of using abdominal ultrasound, we're really not doing this high dose as much anymore because there's a lot of overlap between pituitary and adrenal tumors. And you have to remember, you can't jump to this test immediately. You really have to do a confirmation of that this dog has Cushing's first, and then you go on if you want to try to differentiate between the two. And the rule of thumb is 8-hour cortisol is less than 50% of basal value, is pituitary dependent, but 75% of PDH, pituitary dependent hyperadrenal corticism dogs will suppress with high dose dex suppression. So theoretically, if it suppresses, you will have adrenal tumor. But again, it's less accurate than actually abdominal ultrasound. And a lot of times, I think ultrasound is also helpful because you're looking for masses, because there are some other differentials beside high alkaline and high cholesterol. Again, you can have Cushing's dog and something else going on before the owners want to really commit to all this treatment. Then you may want to just really know what's going on in the belly. The ACTH stimulation test, the sensitivity is actually not as good. A lot of people will throw out around 85%, but that's more of a combination. But if you look at separately, pituitary dependent is around 87% sensitive, but adrenal tumor is only 62%. So anytime you have an animal that you think is maybe adrenal tumor, you really should not be choosing ACTH stimulation test. You're going to miss, about 40% of those cases. So but the specificity is really good. It's around 87 to 95, so much better than the low dose dex, which is probably around 44 to 75%. So if you have any concurrent illnesses, I think ACTH stim is a really good test. And ultimately, some animals even need both. You need to start out with a good sensitivity, and then you finish off with a good specificity. And I like it a lot because it is very short. It's a 1-hour test versus the whole 8-hour. And it is the only test that you could help confirm that there is not iatrogenic Cushing's. So you have all the symptoms, but animal has, chronic, topical steroids, or had an injection, of steroids for a while, and you're trying to sort out, does this have natural Cushing's, or is it something that is truly iatrogenic? That's going to be the only test. And then just remember that colchicine is pretty darn expensive, and so now everyone's trying to do the conserve cost by freezing it. So what you do is you go ahead and make aliquots about 0.2. We do 0.2 mLs aliquots, and you reconstitute in 1 ml, and it comes in 250 micrograms. And it really can be in the refrigerator for 4 months. We just keep it in the freezer. And then so we just kind of pull out. It defrosts almost like within like a minute, and then you could just kind of pull what you need. We don't, it's not really clear how effective it is if you kind of keep thawing out and refreezing, but a lot of times when you're using such a small amount, 0.2s and such, usually you could get away with not having to refreeze any. And I know that a newer paper had come up with IM, because it used to be only documented for IV, but IM theoretically can also work at the lower dose. Because back in the days it used to be a whole 1 vial, but we still prefer IV, because then there's no question the dog did get it in the system, because after you're investing so much in the test itself, I kind of want to be 100% sure it's in the systemic system. The other test that became kind of popular was a 17-hydroxyprogesterone. So this is a precursor to cortisol, and this paper came on where there's animals that kind of fit Cushing's, couldn't prove it, low-dose dex was negative, ACTH stem was negative, and some people measured other hormones, and 17-hydroxyprogesterone was really high in a few cases. And so everyone got really excited about this whole, they call it atypical Cushing's potentially. Ultimately, it's not a cortisol secreting overproduction, but it's actually a precursor. So people thought maybe we should be doing 17-hydroxyprogesterone tests on those questionable cases. It's fine, but the downside is it's not very, very specific at all, and the sensitivity kind of sucks. So most dogs, or I should say probably 55 to 85% of dogs with Cushing's will have elevated 17-hydroxyprogesterone, but also cortisol. So by the standard way, you should be able to still detect it. So it's not recommended to just use this test, and then not do the standard cortisol level. And again, the specificity is not great. It's not as high as the ACTH stimulation test with cortisol. So again, it's not a first-line defense. It's about 74%. Okay, and most tests, I do want to say that a lot of papers will publish both basal and post-ACTH, and that's when you start comparing studies when you're reviewing them. Make sure that, to sort out between the two. The more accurate one is really the post-ACTH, okay? But again, just kind of throwing out both numbers because it depends on what the paper kind of reported. So it's still not something that you should ignore, because occasionally you will have the rare cases that it is only 17-hydroxyprogesterone. So the way that you can kind of get around testing this for this hormone without charging the owner another ACTH stem, which is so darn expensive with colchicine, what you do is when you do the ACTH stem, I always pull another red top, for the pre and the post, and you freeze it. You spin it and freeze it. So if you get that weird, bizarre case, that's like, ooh, I might need to run other hormones, you'll have it in the freezer, the owner doesn't have to come back, and you just send it off there. So I think it's just a very cost-effective way to get more information if you need to.
What incidence of that do you see?
I see people probably seeing less than 5%. I mean, this is very rare. They want to really focus on the rareness of this. I think everyone got really excited about the paper that came out, but the problem is once people start looking at the sensitivity and specificity, it was not great. So, and even that paper, if you saw the cortisol, it were actually high in some of those dogs. So I don't know why. I think everyone just jumped on the bandwagon really quickly, but we're probably talking about less than 5% of cases. And you just have to be careful about, I think a lot of times people will really try to fit a diagnosis to make it Cushing's when you just feel like this has got to be Cushing's. But a lot of times, For all I know, it could be renal disease, renal insufficiency, and that's why they're so PUPD, and you're not going to have azotemia because you only have 66% of your nephrons gone. So, and then maybe you have a high ELK phos because it's non-specific, or oftentimes it's early Cushing's, and I would hate to start treating for Cushing's and find out it's actually renal insufficiency, then you're never going to get anywhere, and that gets really frustrating because it is such a big commitment to confirm this Cushing's, and you want to go through the treatment. So then you have the sex hormone panel. And that one, it's nice because it is at UT, so it's very close. And it really runs a whole entire panel. And the same kind of concept. Occasionally you'll have some other sex hormones that are elevated, not just 17-hydroxyprogesterone. So you save, spin, and freeze it, and then if you ever have to look for this atypical Cushing's that's making other hormones other than just cortisol, you have extra sample. And people talk about, again, atypical Cushing's, and you just have to be careful because there are some adrenal tumors that will secrete sex hormones. They won't do the cortisol. So I think that's a pretty good test, but ultimately you would be doing an abdominal ultrasound anyway. If you find an adrenal mass and you're really suspicious of Cushing's, that would be another good reason to run that panel. The alopecia X, a lot of people use the sex hormone panel for that because some people feel that there are some increases in several of the hormones. But that is actually still somewhat controversial because they had this study with all these Pomeranians that had it, and they compared it with controls, and they also compared it with controls as in Pomeranians without the alopecia X, and then Pomeranians with alopecia X, and then also control dogs that are totally unrelated to Pomeranians. And the results were kind of all over the place. There's ones that did not exhibit the dermatologic changes, but they had high sex hormones. So then people say, well, I hope we don't start to overdiagnose, issues with this whole dermatological issue. But I just have to stress that it really is only the skin changes. Those dogs are not PUPD. They don't have other symptoms. So really, the thought process when you're talking about the sex hormones is that it probably is a diversion of the normal cortical pathway for cortisol to the aldosterone synthesis, and then it kind of goes over to the sex hormones, and I'll kind of show you a slide. So the main thing is salt is a mineralocorticoid pathway, and this is where you're going to go and make aldosterone, and then sugar. The reason why they say sugar is because cortisol will kind of block insulin, and then your sugar can go up, and so that's the corticoid steroid pathway, and then androgen. So instead of going through this pathway, it just all wants to go this way for the sex hormones. So the main question is really, when do you really want to start treatment? And I just think that having this conversation with clients is just so important because you can do all the testing and then ultimately you find they have Cushing's, and then a lot of times owners will start to kind of fall out of the treatment process and the compliance because they didn't realize how expensive it would be or they didn't know what was involved. So a lot of times even when we're trying to diagnose Cushing's, we will really sit down and kind of go over what this really entails. So compliance is really critical because you're dealing with drugs that are really so critical either on a daily basis or a few times a week, and ultimately you can create Addisons. You can actually suppress the adrenal glands too much, and then you're dealing with a very, very sick dog compared to a Cushing's dog that was just PUPD and polyphagic. So I do think that compliance, if an owner cannot do it, for me it's a liability for me to couldn't even start treatment. And it's really significant financial commitment. I mean, when you think about, I don't know how much everyone charges for ACTH stim, but it could probably be anywhere from $200 to $300, and then ultimately you have to do that, after, usually 7 days to maybe 10 days, and then maybe 14 days, and then in a month, and then every 3 months, and then every 4 months. It really adds up. So sometimes if you're dealing with, especially like adrenal tumor, where you have to even test more frequently because the dose is so much higher. If you think about how much the adrenal surgery costs to remove it, probably adrenal tumor surgery, at least here, maybe around, $2,000 to $2,500 or something like that. Ultimately, hopefully that kind of cures the dog versus kind of constantly doing these ACTH simulations, having multiple follow-ups. It can add up. So I think sometimes it's not that bad. And I also want to emphasize that mild or severe clinical signs is really important, because if it's really mild, again, it's so slowly progressive, I don't even bother treating, because I think that it's going to be hard to monitor the animal when they're kind of getting closer to overdose. And again, from a financial standpoint, is it worth it to treat when the animal's really not that bad? Now, but it's a personal decision, I think it's something that just the owner needs to be aware. It's not the end of the world you don't treat. And the other thing that we sometimes will get frustrated owners is when you're actually treating the Cushing's or everything's under control, it really unmasks so many of the severe arthritis that we see, and also the allergies, and then you're combating that all the time, and ultimately you have to put them on steroids for like some dermatological issues, and then you're back to square one, and then I think that's very difficult. But however, what owners will often ask, what happens if I don't treat? Again, it's very rare that you're going to suddenly drop dead, but it is something that you can be more predisposed to diabetes. If I have a Schnauzer, for example, we know that they get pancreatitis, they get diabetes. I just put a huge red flag that this dog might be better to regulate now versus trying to get diabetes first, and then you get the Cushing's later, and it can be a little bit trickier. The dermatological issues, obviously, sometimes you just can't seem to get the skin under control, constantly getting secondary infections and resistant infections. And then thromboembolic complications is another big one. It probably doesn't happen quite enough to, for owners to really be super scared, but at the same time, we do see them suddenly drop dead. They, throw a clot to their brain, or the biggest one would be like a PTE to the lungs. And I also want to stress that if you have a cushingoid patient that you're just doing a routine dental, they're going to be predisposed to thromboembolic issues. Anesthesia can go perfectly, but next thing you know, they just kind of can't breathe, and you don't know what's wrong. And we've had a few cases, where PTEs definitely do occur. So if you do have a cushingoid dog that's either going to go to surgery for adrenal tumor removal or just routine, cruciate, we get tons of cruciates, that are cushingoid because their ligaments are so weak, then ultimately we often will pre-treat them with something, before surgery. I'd like you to go maybe 3 days to maybe 7 days prior. Minimally put them on Plavix because it's generic, so it's very inexpensive. But we don't even know if that really truly helps, because like in people, not everyone responds to Plavix. Depends on your genetic markers. But we often will do it for animals. If you really have a super high risk patient or an animal that has thrown a clot and they can't breathe and they're in oxygen, we will put on low molecular weight heparin, like Lovenox and enoxaparin. But pretty expensive. These heparins are not the standard heparin. Before we used to use heparin all the time because low molecular weight was not really attainable. But you have to be checking coags. You have to get about 3 times above normal before it's considered therapeutic, and the risk of bleeding, it becomes really complicated, so inexpensive. So now really the trend is definitely going with low molecular weight heparins. But the downside is like one syringe is about $30 just for the owners to get. I mean, I usually just write a script and have them get it at Walmart or somewhere, because sometimes they'll sell it by individual syringes. Because if you buy the whole box, it's about $500 to $800. It's really hard to justify that for a client, and then it's hard for clinics to kind of absorb that too, because you don't know how often you're going to be using it. So a lot of times, the nice thing about some pharmacies, they'll sell it by the syringe. And the syringe, however, it's for humans, so it's one injection, per person. And you have a little dog, big dog, so I don't know how proper this is, but sometimes I'll put it in a red top tube sterilely and, have the owners pull it out that way and give it sub-Q. Again, it's probably not the best way, but they just don't sell in smaller aliquots. And it's like it comes in a syringe where you can't really separate it out. You have to kind of inject it into something, and we just put it in a red top. And but usually, if we have a high-risk patient that is going to go to surgery, is cushingoid for cruciate or adrenal tumor surgery, oftentimes we'll start it. And then we'd like to also follow through maybe 3 to 5 days after surgery. Because again, the event can actually happen all around that time. It's not like before or after. But you know, spending even $60 a day in times of by 14 is just kind of quite pricey. And then, of course, risk of infections. You know, some people will say about 55% of Cushingoid dogs have urinary tract infections. And you're not going to detect it on standard UA, because remember, they have dilute urine. They don't have a strong immune response. So just by doing a UA, saying, hey, you know, no active sediment, it's not going to be good enough. If you really have a Cushingoid dog, they probably should be properly cultured at least once or twice a year. And then one other thing I forgot to write down is hypertension. About 80% of Cushingoid dogs will have hypertension. So if I have a set of owners that say, you know what, I can't do anything, I'm not going to test, we're very suspicious, or we do test, but I can't do the treatment, I say minimally get a blood pressure. At least we could control the hypertension with enalapril, you know, because a lot of times they can go acutely blind, they can have other issues with hypertension. It's not going to be good, you know, for the other organs.
Did you say 80%?
Yeah, up to 80%. And that's probably why a lot of times you'll see a little bit of proteinuria too. You know, like it's not unusual for a Cushingoid animal. It's just going on oral steroids, but it does affect the glomerulus a little bit, so they have a mild elevation in protein, which again you may not appreciate if you do a standard UA because it's so dilute. It will even have a very mild protein or negative protein. But if you do a UPC, you know, it could be a 1, you know, or 1.2, something like that. It's not typically going to be in the 5s or 6. You know, I start thinking about primary glomerular disease, but it is a mild elevation in UPCs. But before you do a UPC, you really should kind of confirm that you have no urinary tract infection, because UPC is not going to be helpful if you have an active infection. So if you really want to target this, you have to kind of culture at the same time and do a UPC at the same time. Or culture and then save the UPC, because UPC is pretty stable, and if it's negative, then you can send off the UPC. So Lysodren treatment and trilostane, ketoconazole, L-deprenyl, and radiation therapy and surgery. I'm sorry, before I jump to that, does anyone have any questions on the testing? I didn't include the endogenous ACTH, you know. I graduated from Michigan State. I remember it was so easy because you just run, you know, pop in their little tube. It's like a little bank sliding tube, you know, that from wherever you are, and it goes down to the lab. But you thought, oh, that's so easy, and that's great. I could test, you know, because it is a very good test. But the problem is that it's totally not stable. I don't realize that, you know, we still had to pack it on ice to even go down from one level to the next level of the clinic. So I think from all practicalities and in general practice, it's hard to submit endogenous ACTH because it may degrade, and then you're going to think it's low, and then you're going to think everybody has adrenal tumors. If you are, we were always taught that if you really had to do it, you should pair it with a normal dog, you know, with like a heartworm dog that's just coming in for routine checkups. So you're supposed to pair it together to make sure that at least you won't have one normal. But again, coming out into the real world, I have yet to do an endogenous ACTH because I just think it's too sensitive of a hormone. And again, ultrasound, we're going to find adrenal tumors or not. I don't really need to differentiate it. It's not as difficult. So the treatment: Lysodren, trilostane, ketoconazole, L-deprenyl, radiation therapy, and surgery. So my main emphasis is really going to be Lysodren and trilostane. Surgery, obviously, for adrenal tumors, that is the treatment of choice. We do prefer it on the left side than the right because it's a little bit trickier. I really can't comment much unless Dr. Calfee has anything to say. I don't know where he is. Do you have anything? So supposedly the right side is a little bit harder because all these vessels, you know, who cares, you know, but as an internist, I'll probably whack it out. But I think ultimately, a lot of times whenever we're finding adrenal tumor, the surgeon will say, hey, is there an invasion or not? That's what we're trying to look for. And occasionally you will definitely see obvious invasion into the vena cava when you're doing the ultrasound. And those are not the greatest surgeries because they bleed out, ultimately. And so, and sometimes if you really want to know also is do a CT scan, prior. But sometimes I feel like CT scans and even ultrasounds, when you think it looks clean, you don't know until you get in there. So we still feel that adrenalectomy is still a very good option, but it's still a high-risk surgery. And then the hypophysectomy, and when you I know that in people, they remove pituitary things, all sorts of stuff through a little tiny hole through the nose, and I right now it's really the Netherlands that are really big on hypophysectomies, and I think our learning curve in the U.S. is just way too high. I don't know if Dr. House is here, but I know there are some people in the States that are kind of doing this, but it's not something I could say, oh gosh, you need to go, to whatever university, because it's still a huge learning curve. And it was interesting that the group from the Netherlands, that when they talked about the hypophysectomy in 150 dogs with PDH, again, he's a big guru person that kind of cuts these things. 12 died post-operatively out of 150, and then 127 went into remission, and only 32 of these dogs had recurrence. So it does come back. But I thought it was kind of interesting. And the median recurrence time was about 18.3 months, and it really ranged from 6 to 56 months. But the 2-year survival time was about 76%, and then 71% for 3 years. So I thought that was pretty high, but again, we're not there yet. Lysodren is personally the drug that has been around for a long time, and it's still my first line of defense. It is a derivative of an insecticide, DDT, and it is cytotoxic to cells of the adrenal cortex, but it does seem to spare the glomerulosa, which is the mineralocorticoids. But keep in mind that although cytotoxic effect is present, there's probably some other adrenal inhibition, because sometimes you don't have cellular destruction, but it still seems to suppress the hormone. So we don't know exact mechanism for all the things that Lysodren does. So definitely there's a cytotoxic component, but there's some of them that's actually not cytotoxic. And I think that whenever you're going over, treatment options, when I talk about Lysodren, at least for owners, I remember as a vet student, this whole Cushing's concept was always really frustrating, because it was just a lot of like hormones, negative feedbacks, and all this other crazy things, and they always have a little diagram, and then it's like that last-minute cram note card that you'll do before the exam, and I always could do it right then. But when you're trying to explain that to a client, it just gets really overwhelming. So I try to simplify this using this lawn mowing analogy. So I don't know if it works for you guys or your client will kind of look dazed, but this is what I'd say. I say that, just think of cortisol as grass, and it's growing, and it's coming from the adrenal glands, and it's growing, and you want it to be between 2 to 6 inches tall, okay? And that's why you can remember, because that's what your ACTH stem, you want it between 2 and 6, micrograms per deciliter. And so right now, again, most of the time they're pituitary dependent, so I'm going to say that your brain is over-secreting fertilizer. And I can't shut that off. It's constantly getting fertilized, and now grass is growing, okay? And now we're super, super tall in the grass. So when I actually start the treatment, I want to use a large lawnmower. I can't use a tiny little shears or little light mower. I got to use the big guns. So usually it's a very high dose at 50 mg per kg per day, but you're doing it daily for about 7 to 10 days to really get that grass cut, because it's so high, and I usually tell them it's around 21 inches, because usually it's above 21 for your cortisol level to be considered Cushing. So I want to get it down to 6, but so one big lawnmower, I'll cut it down. But then now if I suddenly stop the lawn mowing, the fertilizer is still going to keep being spread, so then grass is going to keep growing again, and we're back to square one again. We just let it go. So that's where I go over to light maintenance. Okay, so that's where I do the little light mowing, and then I'll go ahead and just do it maybe 3 times a week, which is more reasonable in the dosing, because it's 50 milligrams per kg per week, not per day. So if I lost you, I'm sorry, but it seems to work in my mind, and it seems to, help me remember some numbers.
How often you measure your grass height? Can you do that?
So usually at 1 week time, and then eventually you'll go ahead and do it again in a month's time. Depends on if you have to reinduce. Okay, so we'll kind of go over the details more in Lysodren. So just to remind you of this whole, where does it act? You know, what drugs are acting where? So the key point for mitotane, Lysodren, you know, OPDD, is here. There's some kind of cleavage issue of the enzyme that maybe blocks. We're not really sure, but it is pretty high up, you know, so that's nice because then it kind of blocks all the hormones. Okay, and then you have a little bit over here too, you know, the 11-beta hydroxylase. Okay, but again, the higher up you are in blocking, you could really, I like it because it'll block out all my precursors too. Okay, so anytime I have a weird atypical Cushing or a dog that actually is secreting more than cortisol, then this tends to work 100% of the time. Versus I have a lot of animals that are on trilostane, which we'll go over in details, where hey, it's not working. It's because trilostane does work at a lower level, you know, where sometimes it's not as effective as you'll probably get this 17-hydroxyprogesterone, you know, region, which remember we talked about. Sometimes people can measure and it goes up really high, but right here. So. And then they have these little precursors that are even higher. So anyways, the main thing now is induction. Again, typically we'll be treating for 5 to 9 days. On average, I do 7 days, but if you really look at the ACTH stem, I mean, if I have a standard, you know, 21, you know, maybe on the border of 20, I might go with, you know, even 5 to 6 days. But if I have a dog that's like 35 post-cortisol, you know, it's going to be 7 to 9 days possibly, but on average probably around 7 days for me. And quite honestly, I do it by tablet size. I just calculate how many, I'll calculate like the dog's weight in 50 milligrams times the dog's weight in kgs, and then times it by 7, and I'll get that number. And that number I'll just divide it by 500. See how many tablets I will have to go through, because Lysodren only comes in one size, you know, so I'm not going to do like 3/8 of a tablet, so I'll kind of just round up, round down, you know, depending on my tablet size. And if I feel like I think that the dog might be a little bit more sensitive, I might, you know, cut off a few tablets or a quarter tablet, whatever it is, but that's how I do it. It's important to give it with canned food. It's higher absorption. So if you have an animal that's not responding, a lot of times the absorption is maybe not as high. And it's also a good idea to give with canned food anyways, because a lot of times dogs will really be excited about the canned food because they're so polyphagic anyways, that you know something's wrong if the dog's kind of slowing down with canned food, you know, in particular. And you also even have some people, I like to reduce the amount of food the dog's eating for that induction period. I'll reduce it maybe 50 to 75%. So I'll kind of cut off on 25 to 50% of their food. So you know that they should be eating everything, clean up the bowl. And if you start to see that, boy, they're not finishing or they're slowing down a little bit, something is definitely off. Because you know, there's canned food, there's a little bit less food. And it's just a good sensitive way, a little bit sensitive. And some people even time their animals, and you know, it takes like 5 minutes to eat, but now it's taking 15 minutes or 10 minutes. You know, that's, again, you just have to find any way that you could be somewhat objective about how well the dog's doing. And I can't overemphasize enough that you really have to teach the owners, because I definitely had owners where I kind of go through the spiel, and ultimately the owners just said, he did slow down, but we did, you know, kept on going, and then ultimately you get a very low cortisol level. So again, stop once appetite decreases, slows down, and finish the meal, or decrease in thirst. And on average, you're always going to kind of note that you'll start, this whole decreased appetite is probably going to happen more in the last 3 to 4 days of the induction. Okay? So when you are inducing a dog, I like to do it on a day, the last 3 to 4 days will fall on a day that I'm here. You know, I try not to make it so that the last 3 days is going to be a Saturday or Sunday, you know. So, because remember, you don't have to start induction just because you diagnose it. You don't have to start on that day, you know. I have owners that are going out of town. They can't really watch their dogs. They just start it whenever you can, because the dog's been living with it probably for months to years. So I always give a supply of prednisone, about 0.25 to 0.5 mg per kg, okay. And I always tell them that's the antidote. If you start to see signs, go ahead and give a dose. And usually if it's really due to the Lysodren overdosing, you are going to see resolution of signs probably in about 4 hours easily, okay? And I always try to tell owners not to give it if you can kind of hold off and get to emergency clinic if possible. Because sometimes, a lot of emergency clinics, including ours, can do ACTH stimulation tests, because it does throw off the ACTH stim a little bit if you start prednisone and then you do an ACTH stim. But it's not that horrible. But if you can hold off, I'll tell owners just, come in and then we'll do a stim, and then you give the pred and they go home, or they have to stay the night if they're really that sick. Of course, you won't have the results, so it is something that is during the day. The owners can make it over to your clinic, pull the blood, send it off, and then have them start the pred while you kind of wait for results. There's really no reason why you wouldn't want to start the pred if you're kind of concerned that there may be an overdose. It's not really overdose, it's just that the dog's really suppressed enough. And then a lot of times we will have actually our technicians or nurses to call the owners in the last 3 to 4 days. Just a really quick morning update, how's the dog doing, just to really be sure that they're paying attention and how much the dog eat, just to give a peace of mind. Just because it's just such a horrible disease when you overdo it and then they're just so sick, and then it could be quite costly and preventable. So again, stop Lysodren anytime it's ill, and again, often occurs the last 3 to 4 days. Poor appetite, vomiting, diarrhea, decreased appetite. If GI upset is seen within the first 1 to 3 days of induction, it's really unlikely related to too low cortisol. It is a gastric irritant, okay? So some animals don't handle it very well. So usually on those cases, I'll try to divide the dose. I like to divide the dose no matter what. If I do let's say if I'm doing 1 tablet a day, it's going to be half a tablet twice a day for me. Because that way I can feel like if I could break it down to smaller increments, if they can see some illness, even that half a tablet versus giving 1, it's already gone. They already got the full dose. You can't get it back. Versus half, they're already a little bit off. You still have that little time. And then so if you have a dog that's really sensitive, definitely even consider it 3 times a day. You could divide that tablet, whatever you want, but a lot of times smaller increments and with food is definitely helpful. And I always give it, I kind of treat it like insulin. I always make sure the dog eats first, and then I give the Lysodren. That's something that you may want to. Things that are common sense to us is often not for owners. So I like it because, again, if they suddenly put the food down, don't eat it, then it's like, I don't want to give the Lysodren first and then find out he doesn't want to eat and then he already gave the pill. Remember, the target range for Lysodren is 2 to 6 micrograms per deciliter, okay? And after you reach that target dose, you would go and start maintenance therapy. Some people will wait 2 days. Some people wait even full 7 days. Quite honestly, it really depends. I think that either way, it's fine, because a lot of times if you're getting the results until the next day, or you're going to be out of, not in the office, and the results come in, then you're going to call them. When you do, you have a little lag time. And but once you reach that goal, you'll do the same amount that you were giving in 1 day. You're going to give it within a week. So again, the rule of thumb is usually about 50 mg per kg per week. But let's say you ended up finding that the dog got induced and it was like only a 5-day induction and you're already at your goal. Then that I'll find out how many, I'll definitely tailor down my maintenance dose too then. And then if you go ahead and test the dog, because of course you always have to test the dog before you go on maintenance. That's the other thing that I find sometimes people skip because they're trying to save money, because I just spent all this money on this first ACTH stim to diagnose. Now you're telling me I have to come back in 7 days or so. And I think that's going to be a big problem, because what happens, you're still too high and you immediately assume you're on maintenance. You have no idea where you're going to be at. So I think it's really critical, even more important, that you're not treating a dog that's too low in cortisol. So if it's greater than 6 micrograms per deciliter, again, these are always post-ACTH stim numbers, you want to add probably 1 to 3 more days of induction. So I call it a mini induction. And then if it's less than 1, you're going to have to start some pred. And a lot of times they're asymptomatic, quite honestly, if you're really doing it right. You know, that they shouldn't be too sick, but go ahead and start the ACTH stem, and then you're going to do that for a week and start to wean off, and then you're going to retest again. You know, typically, I would say 3 to 7 days after your last dose of prednisone. Okay, so typically that's going to be probably about 3 or 4 weeks from the time of getting too low of a cortisol. Again, maintenance therapy is 50 mg per kg per week. I'm sorry. And once you are on maintenance, you'll recheck in about a month, and then every 3 months from then on. And at any time throughout this process, if your ACTH stem is really a little bit high, between 6 and 8, you may just want to increase the maintenance. You don't have to do a reinduction, okay? But if you feel like it's really greater than 10, you're creeping up. The longer you wait, you're gonna keep going up and up and up, and then you're gonna start out the whole process again, and then you have to reinduce and all that. So ultimately, oftentimes we'll do a mini induction, and I'll kind of look back on my notes. And the easiest thing for you guys to do if you have a Cushingnoid dog, you eventually see this animal so often that I just kind of make it one sheet, and I'll write induction dose, what the results were, and then the next line, and when they come back in, you're almost like making a log, just dealing with the ACTH stem versus trying to flip through the charts. What was that dose again? You know, because you're going to be seeing this all the time, so that you'll get an idea of where did you start on maintenance, and then that helps guide me about the mini induction, because I knew that when he was at 25 post ACTH stem and was diagnosed with Cushing's, and it took a 9-day induction, I know my maintenance is probably going to be higher, or my next mini induction is going to be a little bit higher, versus a dog that was really sensitive. It just kind of helps you organize your thought process. So iatrogenic Addison's, it's probably the most significant complication, and really you have to check the potassium and sodium levels, and you will need to be on mineralocorticoids if it is too low, just like treating it at Addisonian. My induction of, anytime I start treating a Cushingnoid dog, I always tell owners there's a chance your dog's going to become Addisonian. But it's not the end of the world, because it's actually easier to treat an Addisonian than it is to be treating a hyperadrenal corticism. And so at least you kind of have that set in their owner's mind. And in some countries, in Europe, that's like the standard. They just give super high doses, and they really try to wipe out the adrenals, because they'd rather just treat for Addison's. They'll give pred at the same time, and then mineralocorticoids. So it's not, in the States, we still kind of try to just find this balance. But if it's only hypoadrenal cortisol issues, then it's a little bit trickier. You know, you're just going to have to do close follow-ups only on prednisone only, and that's where I think that we miss a lot of even atypical Addisons, for example, or just standard dogs that are just a little bit too low, because if you're be looking at sodium and potassium, you're not going to find it, because it's not a mineralocorticoid issue. Oftentimes it's a cortisol issue that comes first. And there are some cases where literally they're flat, on cortisol for 1 to 2 years before they come back. And those are the cases where you're pretty much always on pred, try to wean down to lowest effective dose, and then ultimately you will try to stop the prednisone on a very low doses and maybe test about 2 days later or so, just hopefully to not to have the influence of the steroids. Lysodren toxicity. There is a very rare disease called Nelson syndrome, where it starts to expand the pituitary tumor. It's, again, less than 5% probably, and they'll just suddenly become really sick with neurologic symptoms, dementia, circling, and weakness, and it often can occur 1 to several months into Lysodren therapy. And it really just kind of, it has to do with the negative feedback regulation is kind of not working, and then it really kind of blimps out the pituitary gland. And if that's something like that happens, you just have to start low-dose steroids. I mean, you treat it like a brain tumor in certain ways to get rid of the edema, and then you can still resume the Lysodren therapy. So when do we use Lysodren? It really is one of those things where we'll definitely use it if they're not responsive to trilostane. And if it's an adrenal tumor and surgery is not an option, actually Lysodren is a decent drug. It's still, again, my first line of defense, just because of the weird atypicals that we can see, or animals that are making more than just cortisol for overproduction of the adrenal gland hormones. And just to kind of touch base with Lysodren and other diseases. If you are going to be treating Cushingnoid dogs with diabetes, you really have to be careful about hypoglycemia. Okay, the insulin requirements will often become lower, because now you're going to have less cortisol, so there's less antagonism to insulin. So just be careful about hypoglycemic events. And the epileptics on phenobarbital will have a high tolerance for Lysodren, again, due to the P450 enzyme increases the metabolism of the Lysodren. So be careful that it's not unusual to be on much higher doses of Lysodren on an epileptic dog. And so Lysodren in adrenal tumors, they're used for non-resectable adrenal tumors or owner's decline surgery. And the dose is higher, typically 50 to 75, but realize that the induction period is much higher, 10 to 14 days, but sometimes it goes through like 30 days occasionally. But because of this crazy high dose, you just don't know, you really should probably give with prednisone, okay, because you're really trying to shut down those adrenals. But then how do you test for ACTH? You just have to stop the prednisone a few days prior to doing the ACTH stimulation test to see if you kind of successfully reduce the cortisol level. And then if it's still not responsive, you might have to increase by 50%. You're like making big jumps, but again, you feel safer because you're on pred. And then there's a huge range. Maintenance doses, you can see it's almost like double to 4 times or 8 times the normal range of a regular pituitary dependent form of Cushing's. So, why I like Lysodren also because it truly is a chemotherapeutic agent where it actually kills neoplastic cells. So sometimes you can even use it for metastatic disease in the rare case that the adrenal tumor has metastasized. And versus trilostane is not as effective, but theoretically you still can use it. There's some papers on that too. But either case, trilostane doesn't affect growth compared to Lysodren. It actually decreases the size of the tumors. So the median survival time with adrenal tumor with Lysodren is a 32 animal case. It was about 16 months and ranges 20 days to 5.1 years. And then another study showed that maybe 14 animals, it was about 15.6 months, ranges 2 to 37 months. And then for trilostane, you were still able to be successful on adrenal tumors also, but it's a very small number. One dog was 117 days. But the range was like 10 to 18 months. But again, such a small number, it's really hard to know for sure. But the main thing is that those cases with the trilostane, you're just trying to, again, control symptoms, okay, versus maybe Lysodren has some of it to actually shrink the tumor. So how long does a dog live with pituitary dependent? Really, it could be around mean survival is about 2.2 years, okay? The range is 10 days to 8.2 years, assuming, again, the complications. I find that most of our dogs that get euthanized, it's more the complications of having Cushing's versus they just suddenly drop dead. And the adrenal tumors, median survival time is about 16 months, okay, in the 2 different studies. So it's definitely very treatable. It's not too bad, but if you don't treat, it depends on what stage they are, that they may still live, for a while. Let's talk about trilostane. So trilostane Veterol is an inactive steroid analog. It's a competitive inhibitor of 3-beta-hydroxysteroid dehydrogenase. And it suppresses the production of progesterone and also its end products, cortisol and aldosterone. And in the 11-beta-hydroxylase and 11-beta-hydroxysteroid dehydrogenase may also be affected. So it's nice because it is FDA approved now. Before it was kind of a big form you had to fill out to get the medication because it is the drug of choice for the European countries. So just to remind everyone, the whole pathway, trilostane seems to maybe work around here. And then there's also this 3-beta-hydroxysteroid dehydrogenase. So Veterol, it comes in 10, 30, and 60 milligram capsules. And it's definitely going to be more expensive than Lysodren, and it is, remember, it is daily. I threw this picture out there just to kind of remind you, the Scotty breed, they naturally have high elk fosses. Okay, so there's some people call it Scotty hepatopathy. So don't be alarmed if you see a high alk phos in a dog that doesn't have any symptoms of Cushing's. But then, however, this breed is also a little bit predisposed to Cushing's. And I just threw in your handout the article, that kind of came out a while back regarding Scotty hepatopathy and how they're in general a little bit higher than normal, but then they're also overrepresented in Cushing's too. Because sometimes I'll get that phone call, say, hey, he has a high alk phos, and I find it's a Scotty, and kind of, if there's no clinical symptoms, I kind of blow it off more. So, so the dose of trilostane, it's usually 2 to 6 mg per kg per day, but usually you really want to split the dose if you can. And again, if you kind of remember that grass analogy, it kind of even works for the dose for trilostane, it's 2 to 6, but per day. And you really want to increase or decrease the dose, at least on the label it's saying 4 to 6 hours post-pill. We'll kind of go over that a little bit, but the main thing that it is very sensitive at first, where some animals will just decrease appetite and some lethargy. So it kind of blocks those enzymes pretty immediately, but oftentimes the dose will need to be increased over time potentially, but eventually it'll kind of reach a plateau. But you should still always stop it if there's any GI signs. And there's been a study that showed that if you do twice a day dosing, it's probably going to have better control. And you maybe you'll get away with a lower dose compared to a higher dose at once a day. And the reason for that is because we were finding that the length of activity is kind of short in trilostane. So if you have an animal that has high risk of thromboembolic disease or is a diabetic, you really want to have that balance. It's really twice a day would be most ideal, because you don't want to be the second half of the day you're going to be really crazy on your sugars, because your cortisol will be up. So there's some controversies about when is it best to really do the ACTH stimulation test. So there's been several proposals, and the reality is it's probably 4 to 6 hours is probably fine, but some people have recommend 3 to 8, and then another one, if you're doing on BID dosing, they even suggest 8 to 12. But if you really calculate that time, it's kind of like, meet me at the clinic at 3 a.m. Like it's just kind of hard to reach that. So I feel that do what you can, but usually 4 to 6 is currently the recommendation, but realize there is some controversy about when it is best to do it. And the typical ACTH stimulation test is about 10 to 14 days after starting the dose, and then 30 days and 90 days. So very similar to Lysodren, so I don't think you're going to save a lot of money by reducing the frequency of ACTH stimulation tests. And some people recommend that you should only raise the drug after you've been on it for a while, where some people actually wait for 4 weeks. Even though you still need to get that 10 to 14 day test, you may want to just kind of look at it, but unless it's crazy high, then you may want to just say, hey, just kind of hang in there, because eventually it'll kind of plateau out and hopefully be more effective. Or if there is really no improvement whatsoever, okay? And the goal, there's several different papers and recommendations, 5 to 10, 1 to 5. I still do 2 to 6. It's just easy to remember. It's the same as Lysodren. And I do have to say, with both Lysodren and trilostane, I have had some owner that had one case that, gosh, I just couldn't get it between 2 and 6. It would be around 8 or 9, and then eventually you're doing so many stims. Owners are frustrated. They're spending so much money that sometimes I'm like, well, the dog's not clinical. Okay, if you're going to be between 8 and 10, so be it, So sometimes I do kind of give this a little bit loose interpretation of where it should be, but the goal really is between 2 and 6. So if the ACTH stimulation test is less than 1, you got to stop the trilostane. And the good news is that it is pretty short acting, and you have to stop the trilostane at least for 48 hours, and then you reduce the dose at 25 to 50% reduction of whatever dose you were on. Okay. And you can still get almost like an Addison's effect where you have too low of a cortisol. It doesn't seem to always affect the potassium and sodium, but it can be transient, but sometimes it can last much longer. So when this drug first came out, everyone was so excited, but it still can cause, the dreaded, hypocholesterolemia. And the other thing is that it can cause adrenal necrosis, and then therefore they can become permanent Addisonian. So again, theoretically, you're thinking it's just an enzyme blocker. Why should it do that? Some theories maybe because it gets stopped up while the other precursors are still being made, so they can't really kind of, flush on through making the whole product. And now they have a lot of precursors, and eventually it causes the adrenal glands to actually swell up with all these precursor, because it's still making a lot of stuff. And there's been cases that even rupture, And it is known that trilostane, when you go on it, adrenal glands do get larger. So most dogs will tolerate very well, but occasionally will cause low cortisol only. But again, I can't stress that you can get a full-blown Addisonian too. And hopefully, adverse effects are very mild and self-limiting, but up to 63% of dogs treated can have some symptom. So it's kind of high, but at the same time, they're usually pretty mild. They've done, ultrasound images of dogs on trilostane. They noted that pretty much a lot of them will have larger glands before treatment compared to after. And there are definitely documentations of rupture or necrosis. And and there's been reported of acute bleeds too. So again, the enlargement of the adrenal glands is probably a result of suppression of the negative feedback mechanism affecting the cortisol production. And I just kind of threw out this trilostane adverse effects. You read the fine line, how many dogs. And it is kind of scary because I remember when it first came out, a lot of people were kind of quoting this part where I think it's 107 dogs, like 2 of them just died, because everyone thought this was such a safe drug. And then on necropsy, 1 bled out, and the other one had something like adrenal necrosis. So again, theoretically, we don't know why that truly happens, because it's like an enzyme blocker, but it can. And versus, ironically, there's been no acute deaths from Lysodren, as in they don't rupture. Adrenal glands don't rupture on Lysodren, even though it's cytotoxic. So again, they think it's just the gland got bigger and bigger and pops. So discontinue, if you want to kind of go from mitotane to trilostane, maybe the owners just feel that having too many issues with Lysodren for many different reasons, a lot of times because maybe they're going too low on their cortisol level. You want to go on a safer drug maybe that you can control daily. You just have to make sure that you wait until clinical signs return or until post-ACTH stimulation is in the upper reference range. So most people will wait about a month, and some people even longer, to 6 weeks. And dogs previously on mitotane seem to be more responsive to effects of trilostane. So again, it's not a direct switchover. And oftentimes, when you are on a dog, you have a dog that was on mitotane first or Lysodren, you might have to use a slightly lower dose of trilostane. If you're going from trilostane to mitotane, you have to realize the reason why you're doing that is probably because they're not responsive to the trilostane. And that's probably the number one reason, is usually because it's adrenal tumor. Okay. The other thing with adrenal glands become enlarged with trilostane, again, they don't have any kind of cytotoxicity, and if you have adrenal mass, you want to shrink it a little bit. And then you want to wait until clinical signs of Cushing's return, or again, post-ACTH stimulation is in the upper reference range. But it is a short-acting drug for trilostane, so you don't have to wait as long. But I think that ultimately, waiting 1 month for either one is not wrong, because again, you can be cushingoid for a while, because they've probably been cushingoid for some time, just to be on the safer side. If possible, I still am a big fan of making sure you do a ACTH stimulation test prior to switching over, just so you know where you're at. And standard induction dose you would still use for the mitotane, but again, it's going to be a little bit more sensitive due to the adrenal hyperplasia from the trilostane. Okay, so I think that just be careful about that 7-day induction thing where you maybe could just do 5 days, but depends on when you start. And that's why with Lysodren, anytime you start with Lysodren, you really should have a pre and post ACTH stimulation test. So which one do you really want to use? It really, they're pretty similar in certain ways where both can cause Addison's. And if you look at the actual survival time, there's really not that much difference. Okay, so median survival for mitotane was about 708 days versus 662. There's a different range group, but really it's not huge. And in that particular study, they actually had 11% die of pituitary-dependent disease, 17 were actually probably could have been related, and then 38% was not related at all, and then 34% unknown. So I think ultimately similar in its efficacy, and now you just have to kind of talk about the pros and cons of each one and what you're most familiar with, but the cost is actually going to be more expensive on Trilostane because it's a daily medication, and right now I think it really doesn't save you the money on doing the ACTH stimulation test because you still have to do the monitoring. Again, my goal is between 2 and 6, and some people have proposed like these cortisol creatinine ratios. You see, it's really not a good way to monitor. They did a study where 6 of them still went to hypocholesterolemia, even though there was good control. I just think ultimately urine cortisol, creatinine, cortisol can be high for so many other reasons. I don't like to use that. So I don't know if you guys remember, there's like a recent paper regarding pre-cortisol only. Maybe you could just do a single test, so therefore you don't have to spend the money on the colchicine, and it'll save the client some money. So they did 147 of the 168 dogs. They found that baseline cortisol between 1.3 and 2.9, or less than 50% of the pre-treatment baseline cortisol, was actually showing that it's acceptable control. So when you use that kind of range, just using a single number, some of them still got misclassified, but I think that if money is super tight, I don't think that's the end of the world to try that, but realize it's not perfect, but it's something that could give you an idea that maybe you could just use pre-cortisol. Another study that came a little bit later thinks it's not as great, is 95 of the 148 dogs. They felt that if you combine, if you break it down to baseline as excessive, optimal, and adequate, when they were actually looking at the post-cortisol level, which is actually more accurate, they found that 36%, about a third of cases were actually misclassified. So you just have to kind of be careful, with only using single cortisol values, but it's something to think about too. And then I'm going to briefly kind of go over the other 2 drugs that some people utilize. It's ketoconazole. It really interferes with the gonadal and steroid synthesis, but it's a P450 inhibitor. And it really, the problem with this drug, it's not good long term. You might get some success initially, but most of these dogs are going to be on it for life. So I have yet to see a ketoconazole responsive, well-maintained cushingoid dog. And but it does have its benefits, in a sense that it's easy to get, and a lot of times we'll use it in cases that are ready to go to surgery for adrenal tumors. You could temporarily kind of suppress things a little bit before you go to surgery. And typically you have to start out with a low dose and you work your way up to eventually 30 mg per kg, and you divide it, So it'd be like 5 milligrams BID, and then for a week, then 10 milligrams BID, and then eventually 15 milligrams BID. But remember, you can have vomiting, anorexia, diarrhea, weakness, pretty much the same thing when you suppress too much cortisol. The other one is L-Depronyl, the Anapril. It really sucks, I'm going to be honest. Everybody, sometimes people always say, hey, owners can't afford testing, can't do this. I mean, that's fine to try it, but if you really want Cushing's control, it's less than 20% effective. Okay, I'm sure that you maybe have tried it and maybe thought maybe there's some improvement. I think that it's, again, the standard cushingoid that's really overproducing a lot of hormones. It's not going to do diddly. But a lot of times these older dogs have cognitive dysfunction. It may be beneficial there. So is it going to hurt the dog? Probably not. And the thought is that the problem is that when you think about ACTH secretion, it's actually from the pars intermedia and the hypothalamus, but pars distalis, but really they have a dopamine effect. It's a negative feedback system for the pars intermedia. So theoretically, if you lower dopamine, maybe that might help. But the problem is that you still have the other part of the pars distalis that's making a lot of corticotropin release, CRH hormone from the hypothalamus. So the key point is not nice in theory, but only kind of blocks a little section of the pituitary.